now for the next panel discussion on adherence and the patient support. I request all the panelists, Dr. Sanjay Kumar Mattoo from Central TB Division, Dr. Somashekar, ex-director NTI, Dr. Shailendra Bhatnagar is not here, so Dr. Anurag will be here from STDC, Uttar Pradesh, Dr. Sameer Kumta from the Gates Foundation, Dr. Nusrat Shafiq from BGI Chandigarh, Mr. Ganesh Acharya, TB survivor, and Dr. Onali. Yes, Dr. Onali is here. Dr. Onali Rajapakse from Sri Lanka. So, ma'am, please, we all request all the panelists to be on the dais. And also, I request Dr. Karikalan to be as moderator for our session. Thank you.
Sorry, really. No, I just put my bag where I shouldn't have. Forget, sorry. So good afternoon, one and all. So I'm Dr. Karikalan representing ICMR NIRT. I will be moderating this quick and rapid session considering the delay we had. So as we all know that the session is on TB adherence and medication adherence as well as patient-centric care for patients. So a quick 2 minutes introduction that we all know that adherence is of paramount importance. We will know that adherence is invariably determining the TB treatment outcomes, whether it is mortality or reduction of incidence or whether it is treatment success or not. There is a meta-analysis in 2018 which published which says that even missing 10 doses of medication will have a hazards ratio of 5.9. It will increase the unfavorable outcomes by almost 6 times. So we have a adherence behavior is very complex. We think that patients will automatically take the medication, but that doesn't happen. It is determined by a variety of factors. It could be individual knowledge, it could be the risk perception, it could be the awareness, it could be driven by the quality of care given by the health system, as well as the community level factors. So adherence behavior itself is very complex. So we have a very eminent, panelists sitting here from diverse backgrounds. From the program we have, from the research side we have, from the public-private partnership we have a distinguished participant from another country. We have a clinical pharmacologist. We are going to just delve into the different aspects of TB adherence and patient care from these panelists. So my first question goes to our respected Dr. Sanjay Kumar Mattoo, our Additional Deputy Director General, as well as the Vice Commissioner of the NTEP program. So being from NIRT, when it comes for adherence, we always talk about the importance of DOTS. DOTS was tested in our institute. Model DOTS project was introduced, and we thought that DOTS is the best strategy for, ensuring the adherence and treatment outcomes. But since 2017, sir, we have shifted from DOTS, and then we have moved to daily regimen and fixed dose regimen. So we have a 7 years of experience in FDC as well as the daily regimen, where the patients are given non-supervised treatment, where they are given the medicine they are supposed to take, and then they coming back after 10 or 15 days. So whether this practice of providing non-supervised medication to the TB patient, what is our programmatic experience of improvement in the adherence in this past 7 or 8 years? That would be my first question for you, sir.
Thank you. Actually, when we are seeing this previous panel and this panel are somehow correlated with each other, and like shortening of regimen adherence are directly related with this particular topic. And as you mentioned that adherence is a very important, and when we want to see the success rate and the relapse-free success rate, actually we want to see this adherence is very important. And as you were saying that earlier we were having the intermittent regimen. It was thrice a week we were giving, but it was DOTS, the medicine were giving in presence of the healthcare service providers, and that is why the adherence was better. But then new evidence came, and as we know that whenever some new evidence comes, it comes with some advantage and some disadvantages also. So when you are putting the patient on the daily regimen, it becomes very difficult to observe, and the patient has to come. They are so having the daily wages losses are there. So these were the concerns which were there. So with the daily this FDCs comes. So FDC, how it helped the program division for adherence, basically first thing that a number of pill burden, it decreases the number of the pill burden. then usually when we are seeing that if you are giving the loose medicines in different persons are either forgetting them, that they don't know the storage also it helped, because it is one type of medicine, it has to be given as per the weight band, so they know that is a one type of medicine, it has to be taken. But the forgetting the medicine, so it helped that the person did not forget, because it is one type of medicine also. With the loose medicines they have some selective approach also, like they were knowing that after taking this medicine I'm having the red urine color, this might be hazardous, so this prevented they were not able to identify which medication they have to select and they don't want to select. So this is how this has helped. There were some challenges also, like for adults we are having this FDCs for all the four medicines are there, but for the pediatric age group we are not having these FDCs. And this is like FDCs are of the three drugs only, and there is a one drug, the ethambutol, which is provided as a loose medicine, because it is a hygroscopic, it cannot be combined with, so we have to give it separate, and it is usually we are giving the adult formulation, that is crushed. So in the pediatric formulation when you are providing, and if it is not a child friendly, then it poses the challenges. So this is one challenge we are facing. Then second challenge, like FDCs we are having for DSTB, but for DRTB FDCs are not available. Again, this is the one challenge we are facing currently. But if you want to see overall, FDC has been helpful and they have provided a good adherence under the programmatic conditions. Yeah.
So what we understood is that FDC has been important in improving the adherence, but there are challenges in adapting that to DRTB as well as the pediatric doses. That is what we got from Dr. Mattoo, sir. So the next question in this relation goes to our Dr. Madam from our PGA Chandigarh. We have Dr. Nusrat Shafiq. So, Madam, you are a clinical pharmacologist heading the Department of Clinical Pharmacology Unit at PGA Chandigarh. So, as you know that drug tolerability and side effects are an important determinant of treatment adherence. So I remember, the gastro related side effects are almost, experienced by some 15 to 20% of the patient. So this could be one of the impediment for the drug adherence. You must have a lot of experience in your clinical trials when you are trying lot of different regimens, shorter regimens. What is your observation about this drug tolerability and side effects within your clinical trial settings? And what is your understanding when it is getting implemented into the program, how these kind of tolerability issues could translate into adherence outcomes in larger program? It will be nice to hear your inputs, madam. Yeah.
Thank you. For putting up this question. Foremost, I would like to mention that I draw my learnings through the clinical trials that you mentioned, and also from our antimicrobial stewardship program, which we had, and wherein we receive a lot of queries from within the hospital and quite often from outside the hospital related to requirement of modified regimen because the patient is not able to tolerate, or there are adverse effects which warrant the withdrawal of the ongoing regimen. So that's the understanding from which I'll be taking up your question. The problem is kind of underreported. It is, you mentioned some percentages, but I would like to share that it is rather underreported. Importantly, one important fact is that the benefits appear later than this, and they are not so tangible in the beginning than the side effects. So when the temporal profile favors or misfavors the side effect more than the benefits, then it is very likely that the patient will take himself or herself off, if not for the entire duration, but for some duration. They do that very frequently. They do that, and get therein lies a very important challenge of getting them back to the treatment. There are certain side effects where you can afford to get the patients back after a minimal level of counseling. Say, for example, if it is gastroenterological side effects, you can, with little bit of counseling, you could get them back on board. But when if it is drug-induced liver injury, which is rather of a more severe category, you do need to take off the patient, and that number is also, I think, a kind of underreported. And unfortunately, as you would be knowing, a lot of this information is not captured in our Nikshay portal. Every day, on a daily basis, within a hospital setup, which is a tertiary care setup, not largely dedicated to the management of TB patients, but happens to see a lot of them. We have nearly 1 to 2 queries arising from different areas of the hospital for unmodified regimens because the patient could not tolerate. So yes, the problem is indeed there, but as I always say, the benefits have to be seen juxtaposed to the risk, and benefits invariably, both in the overall scenario and at individual level, outweigh the risk. So that has to be communicated repeatedly unless in some situations where you are pushed against the wall. That is largely about the conventional regimens which we use for pulmonary TB that we're talking about. When we go to MDR TB and XDR TB, the regimens get more complicated. BPALM gives some solace, but we are yet to see how things roll out in the future. But for other regimens that we had till some time ago, the side effects and tolerability was a big, big issue. And literature itself suggests that these percentages could be very, very high. And there, the kind of toxicities that we were dealing with went beyond the realm of liver toxicities. So both these issues, I mean, this issue is quite important, rather understated, and rather poorly researched. So we but important thing is most of it would occur quite early in the treatment phase. So that's the point where counseling and mechanisms to detect it early, have alternative regimens, the strategies to get them back on the proper regimen should be in place. So those are some of the things that I would like to say. And then there is a need to identify those who are at risk. And that's where I think a lot of work needs to be done. We have preliminary evaluated these in our settings, but it has to be on a broader scale where we, beyond saying those who are likely to be treatment failures, we also say who are going to have a higher incidence of risk. We identify those profiles and have a plan in place for addressing those tolerability issues as and when they arise. We have been rather there's a paucity of literature about side effects like ethambutol induced ocular toxicity. We all along we have always talked about hepatotoxicity. Ocular toxicity is another thing. Bedaquiline is very much there. Cardiotoxicity, okay, we are kind of comfortable about it. But what we are not comfortable about is the side effect that we are not going to see immediately, and that is associated with the its fallout on the antimicrobial resistance. Bedaquiline itself for TB, but moxifloxacin and linezolid for antimicrobial resistance. That's something that in a country like ours we have to be really watchful about. Yes, tolerability is an important issue for patient for adherence to treatment. Counseling could be very helpful. Methods to detect any kind of toxicity signs or symptoms appearing early on in the treatment should be in place. Alternative regimens with this strategy to bring back the patients on the original regimen would be very helpful. Yes.
Wonderful, madam. So you have given also, both the problems as well as the solution which is needed for addressing this important problem. Integrating that side effects education with the patient as well as the family caregiver as well as the frontline health worker could be a very valuable thing. So that could be a scope for an implementation research actually, which could go into the program. So next we will go to Dr. Somashekar sir. Sir, there are three factors which is responsible for adherence. Like, one is from the patient side as well as from the health system side as well as from the community side. There are a lot of social and behavioral and, cultural determinants which drive adherence. For example, poverty could be one, important determinant which determines whether the patient is adherent to the treatment or not. So we have cultural issues are there. So there are a lot of psychosocial issues like alcoholism is a major impediment for drug adherence. Substance use and tobacco use is a major impediment for drug adherence. So the vulnerability of the patient determines these adherence in a larger way. So that is why we say that, person-centric approach is very much needed and differential care approach is being prescribed. But from our understanding, differential care approach is very resource intensive, and the frontline workers are already strained with more works. How it is feasible to implement differential care intervention for this vulnerable population within the program setting? What kind of things to be done to do this differential care intervention for different vulnerable population in an evidence-based way? If you could provide some inputs, that will be good.
Thank you, Dr. Karikalan. Just I would like to reiterate two things what Nusrat Madam and Dr. Sanjay Kumar Mattoo has told, that a previous discussion also, there is a general principle is, first thing is, when there is a chronic treatment, when we give TB treatment, one is counseling, very important, 5 minutes before initiating treatment regarding the side effect, duration, is there any change in regimen. That is the first principle that we need to do for the counseling. And during treatment, monitoring, clinical monitoring. Actually, the program always prescribes that it should be by a medical officer. Every month should be there. And in between, when the treatment supporters are there, always. The third thing is, yes, DOT is very, very important. Physical observation, because DOT is not just an observing, it is a building their rapport and interactions. That gives the more strength such that the patient can continue in this one, complete the treatment. Our study, NTI did a national default study. That time we used to call default study. Now you cannot call default. Lost to follow. It was found that there are two things very important why patients used to lost to follow up is, one is alcoholism, as you rightly told that. The second is adverse drug reactions. It is when I say that alcoholism, now tobacco also includes substance abuse also there. These are the things. The differential care approach is, yes, it is resource intensive, but the thing is, now we have a different programs are also national program. You have to tie with alcohol addiction or substance, this one. The mental health program is also there. Yes, most of the TB patients, because of the delay in diagnosis, they are having a depression and psychiatric problem also there. We need to address that. So we have to tie up with the mental health program. Yes, it's feasible. And then tobacco cessation centers. Studies have shown that those who are having continuous ever smokers or continually taking the tobacco, there will be non-defaulters also. So these things, yes, you can use the available resources and you can tie up with that. Sir, that you mentioned one more, this one is regarding that comorbidities. Adverse effects, we know that which are the risk factors who are going to have the more adverse effect. Is it alcoholism? Is it the age? Madam has told about the liver DLI, liver-induced drug-induced liver injuries also, DLI is also there. We know that alcoholism is the one reason for that. Is there any other liver-related issues are there that we need to take initial itself, such that if you identify the risk factors who are going to get that, they are so that you can predict that, okay, these are the people, those who are going to get the adverse effect. Managing adverse effect is also very, very important thing, such that if you manage the adverse effect, you can take care of that. Tie up with the programs, tie up with the other programs also, managing adverse effect also, you can always this. And we need to understand, when we are managing comorbidities, the patient will be having other comorbidities, drug-drug interactions. Drug-drug interactions, if you don't address, even though patient is adherent, outcome is going to be poor. So we need to take care of those things also.
Thank you, sir. So having a kind of a vulnerability index based on the socio-economic and cultural and other vulnerabilities will be a useful thing at the baseline when the patient is starting the treatment. That is wonderful. And then we are going to Dr. Onali from Sri Lanka. So he is our distinguished, panelist from other foreign country. So I have two important questions, Dr. Onali. One is that what is the kind of adherence and treatment outcomes which you are having in your TB program in Sri Lanka? And second is very important from a patient care perspective. Sri Lanka is known to have a higher human development, and HDA rank is very high, where there is a lot of social support interventions are going in general. We would like to know in what way the TB patients are supported in terms of empowerment or social support or addressing stigma. What are all the social initiatives which is being done in Sri Lanka? These are the two questions for you.
Yeah. First of all, I should thank the union and the ICMR and all the organizers of this event for actually inviting me to represent NTP Sri Lanka. So it's a great honor for the country. Yeah, so moving back to your question about TB in Sri Lanka. So compared to other regional countries, Sri Lanka, I would say, have a lower case burden. So our incidence is about 62 per 100,000. So about 14,000 is the case incidence expected from the country. But the challenge is, at the moment, we are detecting only around 9,000 patients. So 1/3 we are not detecting, missed. So moving on to treatment outcomes, actually, our loss to follow-up rates are low. It's below 5. Conventionally, it's been below 5. And for latest 2023 cohort outcome, it's 3.4% only. But the alarming thing is death rates have been a bit on upper side recently. It has gone up to actually 9% in 2022 cohort, but now it's gone down to 8%. Actually, the thing is, when a patient comes into contact with the health system and is diagnosed, usually they comply with the treatment. But what we see is there's a delay in coming to the healthcare facility. And also we see that the comorbidities, as mentioned earlier, also the comorbidities, especially in these deaths, among deaths, poorly controlled. So these are the immediate causes we see as leading to deaths. But when we look at the underlying root causes, it's generally, of course, patient empowerment, counseling has to be done, and then financial issues, as mentioned earlier, again, daily wages, losing income if they come for treatment, those things are there, and also stigma. So yes, moving on to your next question about what we are doing to improve these conditions. Actually, at the moment, I mean, conventionally, we been treating patients with a more healthcare center prioritized approach. But from that, now we are moving on to patient-centered community-based care. So one main aim is to improve patient accessibility or the community accessibility for diagnosis and treatment. So at the moment, we are trying to incorporate our TB diagnostic services with the primary healthcare units. That is the most ground level curative care services in the country. So we are trying to do that, to implement that. And at the same time, the novel innovations like, the community-based portable x-rays, then point of care PCR testings, patient-friendly or the community-friendly innovations, we are trying to improve those services so the accessibility is more. And again, from 2024 January onwards, we are using BPALM again. So for MDR patients and with ambulatory care. Again, for preventive treatment, we are using friendly regimen 3HP. Now we are moving on to those things. And then again, we know that after COVID, the dot services, I think every nation faced a drawback. So, and also in our country especially, we had a financial crisis also following that. So it's now more like in our healthcare centers, once a TB patient is diagnosed, we sort of have a talk with the patient, and during that talk we give the education, counseling, and all those things. And usually patient is accompanied by a caregiver, so we include that person also in that dialogue. And then at that moment, actually, there is sort of a risk assessment, as mentioned earlier. Again, I think we have so many common things between this aspect. So if usually if we believe, or if the care provider believes that he or she, the patient, would have good compliance, actually we give that responsibility to the patient and the family member to support. So it has been shown, I mean, it has shown good results. Loss to follow up, it's only 3.4%. So I think we should empower the patient and give more responsibility to the patient. So what we see is that he or she, the patient, has risen up to our demand. So, but at the same time, if we identify any risk factors for loss to follow up or poor compliance, we closely follow up those patients. With limited resources, we have the field visits and all those things. We focus more on those patients. But of course, we have nutritional supplement for each and every TB patient. We give monthly. Financial support is also there. But at the moment, we feel that it is not adequate. Actually, we need to improve on those services.
Good. So uninterrupted care and as well as community-based care is something is the message which is coming from Sri Lanka for improving the adherence. So now, we will reserve the questions for a few audiences, few questions. Later we finish all the panelists. We have Dr. Anurag from representing Uttar Pradesh. So Uttar Pradesh is known to be a bigger state, as well as the burden of TB is disproportionately high in the state of Uttar Pradesh. If I remember, it is 20% of the total notification in the entire country. And it is also a state with, more of migrants and high burden cities, as well as hard to reach rural areas. So there are a lot of vulnerable population within the state. So what is the programmatic experience of ensuring the adherence of these urban poor as well as the migrants as well as the rural poor in your state, sir?
Thank you for inviting me in this panel discussion. As far as the UP concerned, most of the point about adherence and loss to follow-up discussed by previous speakers, the cause we know very well. As per our experience, when we move in the field, we interact with the patient or with the treatment supporter. The main point is comes from the patient side, is that when they feel problem in treatment, side effect or toxic, then they complain that nobody in the program is listening our carefully. So as per the previous speaker says, the counseling and the strengthening of the health and wellness center Ayushman Arog Mandir with CHO and the treatment supporter in terms of side effect of the medicine, the counseling and the strengthening of the health and wellness center and CHO and the treatment supporter in terms of the adverse effect of the medicine, and what is the available at the periphery level, give them assurance, listen them carefully, and some medicines should be available at the periphery, I mean at Ayushman Arog Mandir. So one thing is to listen patient carefully, and they feel someone is there in the program who has worried about him or her. This increases the trust of patient in the program. So in UP, we are focusing on this. As I am from STDC UP, so we are in our all training. We must say to our staff that please listen patient carefully. The one thing that increase their interest in the program and the confidence and the trust. So by this, adherence can be good in program. Second thing, in periphery, as we know by the from the treatment supporter and from the patient, that when patient feel symptoms free, so he used to leave the treatment, and so at every point of interaction, whether the treatment supporter, with CHO, with medical officer, with NTP staff, counseling is must for the adherence, for adequate and uninterrupted supply of drugs and the treatment taken. What is the role of this? That if patient leave the treatment, then chances of MDR is more and more. So this point should be clear to the patient. If he or she will not take the regular treatment, chances of MDR is there. these two things will definitely increase the adherence of patient. This is the experience of STDC UP or the EP. Thank you.
So, like Dr. Anurag has said that, the counseling as well as the communication with the patient is very important. Just 2 points. There was a, editorial in Hindu which said that it was a study conducted in John Hopkins. If the doctor can spend 40 seconds with a cancer patient, then the quality of life of the patient is improving a lot. 40 seconds. And there is a study in India, I forget the state in which it was conducted. When the TB patient has a very positive encounter with the healthcare provider in the first encounter when he visits the patient, then he is more likely to be adherent. But if it is negative, then he is more likely to be LFU. So, like you rightly stressed, sir, that healthcare compassionate communication is the fundamental thing for ensuring the adherence. Thank you for highlighting that. Then we are going to our TB champion, Sri Ganesh Acharya. Sir, we know that now we are coming to the elephant in the room, stigma. We have been speaking a lot about stigma, but nothing has been done fruitfully to address stigma at the patient level, at the hospital level, or at the occupational level. Stigma is a direct impediment to quality of care, as well as it provides a lot of negative outcomes in terms of treatment. So, as a TB champion, what would be your recommendations for addressing the stigma which is surrounding the TB, as well as what new could be done? For example, patient support group and engaging patient champion is being recommended as a strategy for addressing and mitigating stigma. In what way we can amplify the engagement of patient champions across the country, across the districts, and across the villages? Please provide your insights.
Good afternoon. Thank you for having me here. And this is the real, patient involvement in the such innovation. I think, hope in future also continue to, patients should participate in such meeting because patient's voices matters. So stigma, I think before addressing the stigma, so first that, I would like to share my story, when I diagnosed TB, so it started from my own home. So my own people started the physical distance. So I was 4 years in the homeless. Today I'm standing here as just similar to like you, but I was in completely homeless. So that is very different, and we suffer and we survive a lot there. And that is stigma. And again, I'm a symptomatic TB patient. I'm very thin, very weak. Even I cannot move from one room to another room. How can you imagine that stigmatized person had to go in a healthcare setting? So when I go to the primary center in nearby my house, so there is not all facility available. I have to run to the peripheral or much more special hospital. There, go in the morning, and anyone asks what happened to you in the that getting the paper that I'm coughing, I have a TB, and then I have to, and again, in queue also I have stigmatized. So I'm not talking about healthcare more, because you always know the healthcare setting also in stigmatized to blaming the person. Okay, you have done this, somebody used the defaulting such kind of word, like a criminal. So it's very depressed, even for the delaying the treatment. So I am, half diagnosed or fully diagnosed, but still not started the treatment. So there is also the very difficult. And today I am going to more in not in the hospital education level, and also the other institute like a workplace also in very difficult to be as a survivor. So TB is a curable. So as an audience, I think please listen. TB is a curable. This is scientific defined long ago. So what's about stigma? So TB is curable, but we have to fight the battle is the social also, emotional also, that attached to the stigma. So people forget about only they deal with the bacteria. So deal with the bacteria, but not with the human being and society. So first, human should be prioritized before the bacteria also. So this is how we suffer. So I think this innovation, addressing the patients, it had to be patient's voice matter. So if I am a cure patient, I think my experience being a patient to tell the story to others, this is very motivating and giving the hope, and stand together, and that patient build the, empathy. This empathy overcoming the stigma. So I think today I also represent here to the so many women suffer stigma more, especially for women living with TB. Even go to the intersectionality, like who are in diverse community, but the lead or underprivileged community, or from who are the mine workers or tea garden workers, or is very suffer very badly stigmatized. Not only the telling the stories and the way that involving the patient in the such program, this is a powerful way to address the stigma. I think another last point I'm telling, stigma everywhere. We have to think about more to how to patient had to involve in other like counseling. Yeah. So in healthcare setting, there is no counseling specify the counseling. We're only talking about counseling. I'm just giving the. Have you heard about listening by the patient, TB patient to you as a doctor or clinician? No, we don't have time. We are only dealing with the bacteria. So mental health. We talk about mental health. Have you done about any first aid counseling for the mental health for TB patient? Not at all. We have to go at the big psychiatric ward. So I think this is very difficult to access the such very essential services. So that model of care should be redesigned. I think this is very old pattern. 10 years, 20 years, 50 years, we only listen the counseling. So I think this 25 lakh notify people, out of 5 lakh also tell the current patient, I am a TB survivor, I can treat, why not for you? I think this is going to be a huge impact in the future. So takeaway message for everyone, to overcome the stigma, I think this patient can only have a power of the storytelling, do the counseling, even for the mental health. Oh, don't cry, there is a way. This sympathy overcome the stigma. For the recommendation, I think in future that online community, everyone is, I think somebody thought about the online, it doesn't mean a rural setup. I think that is very bad comments. In rural also, localize the language. If support group for the patient in the rural and even for tribal population, if I'm locally, I'm sharing the story for my own tribal population, that going to impact more. The online should be in TB counseling, TB patient, even for survivor-led initiative. This is very important, even for online also. Why not? So this is, we have to invest in the person. I think that I'm estimating that not only the number in the thousands, it's the 25 lakh even notify. I think we should have this. This is very potential for the counseling, for the overcome the stigma. I think I would suggest the program should take this all survivor to in the program is a central response of the TB response central point. And one day I think definitely this innovation. I think we are the product of the program. Please, we are treated by the program. So this is the innovation. We are a product. I think use us, invest us. I think the result, definitely this survivor-led initiative going to change the TB. Nobody can do. Even TB is curable long ago. But what about stigma in human? So we can humanize the disease. I'm challenging in this audience, even scientific way. There is an emotional, social battle. So that's why the survivor-led initiative can do, an online platform is a game changer for the future. Thank you.
Beautiful. So you have very crisply have told, very elaborately have told about how survivors can own this entire program. And also the concept which you told about the first aid for the mental health trauma, that is very important. We always think about the biological side effects, but we are not looking into the trauma which the patient is coming there. That is an important thing, sir. So in the interest of time, then we are going to Dr. Samir from Gates. Sir, from your experience, there is a lot of initiatives from Gates Foundation to implement digital adherence technologies to improve the adherence among the TB patients. So there has been 99 dots, there has been MOM and video dots. So what is the overall outcome of these technologies in terms of improving the adherence? That is my first question. And next one is there an possibility of, there is a lot of talk about harnessing the potential of artificial intelligence and real-time tracking to improve the adherence? Is there any innovation opportunities to implement such kind of things to improve the adherence in the Indian population? And is there a innovation to identify any kind of biomarker to measure TB adherence at the facility level, a point of care, adherence measurement? These are the three questions for you, sir.
Thank you, Dr. Karikalan, for the opportunity to participate on the panel. Like my earlier panelists mentioned, I think digital tools are a patient adherence support system, but I think the doctor patient or the healthcare provider or the public health staff and patient engagement is crucial. I think nothing can take that away, and so I want to start with that caveat. So we looked at several digital adherence tools or adherence support mechanisms, and this was a joint initiative taken under the leadership of the TB program, but by USAID and the Gates Foundation. And we put out a grand challenges for innovators to come and develop adherence support mechanisms. And there were a couple of innovations that came through, and this was way back in, I think, 2014, 2015. There were several sort of adherence support mechanisms that came through, but two or three of them actually were taken up, and we collectively invested in trying to understand acceptability of these mechanisms, how useful they were, accuracy, costs, predictive values, etc. One of them was 99 dots that was developed by Everwell Health Solutions, and there it was a blister placed, a sleeve placed on the drug blister, and every time a patient popped a pill, the underside of the pill would have a number that he or she could dial, and it would ping at a back-end call center or a IT system, and create a signal that indicated that the call correlated with patient ingesting the medicine. The other technology was medication event reminder monitors, or MERMs. These were like basically like a box, and opening and closing of the box was correlated with taking of the medications. The box had a SIM card on the side, which would send a ping to the backend IT system to indicate that if the patient had taken medicines or not. Video dots was fairly simple. It was a patient actually filming himself or herself while taking the medicine and sending that information back. I remember there were several other technologies also at that point of time. I think there was some ink that was available that in a on a paper that could actually indicate adherence, but these three tools were actually tested out rigorously, and Dr. Karikalan, Dr. Beena Thomas and Ramnath Subaraman, you were also involved from NIRT at that point of time. I think 99 dots was easy to use and easy to deploy, but some of the challenges were around families having shared telephones. So if more than one family member had the same number, then it was really difficult to use 99 dots. Also, there was a lot of patient fatigue. So having to dial a number every day for 6-9 months is not easy, and there was a lot of fatigue. So people who were taking medicines were not necessarily calling after a point of time. So the negative predictive value was really low for 99 dots. With MERMs, actually, they worked really well, and the opening and closing of the box was well correlated with drug ingestion. But I think cost was an important factor, and the cost of MERMs a couple of years back was between 5 and 7,000 rupees. Of course, those boxes were reusable, so you could use it for more than one patient at a time. But despite that, I think costs were a huge challenge. And those boxes would wear off after a period of time. So there were several modifications made in some of these technologies. I do feel that the MERM is still of great utility, especially for drug-resistant TB. Some of the panelists on the earlier panel also mentioned about the need for being able to track dosing implementation or daily drug ingestion, because TB medications are unforgiving, and we are hearing challenges around even bedaquiline resistance developing over a period of time, and we really need to protect some of these medications for TB patients in the longer term. I just one or two other points around these digital tools. One was the program took a decision to integrate it with Nikshay, which meant that all of the information that was coming from these tools were available in Nikshay and therefore available to the program staff on the ground or the program managers to actually try and triage those patients who are in need of support, and prioritize them over others who may be taking medications regularly over a period of time. That's not to say that they need to be ignored, but I think just prioritization would have helped. You asked about AI, and you also asked about biomarkers. So I think biomarkers, the one thing that I want to talk about is urine INH testing. And, so there is a tool that is available. I think it's called IsoScreen. It's fairly expensive, but there are opportunities to actually reduce costs with local manufacturing if that's possible. But the tool actually measures INH metabolites in urine and shows a color change. I think purple indicates not being purple or blue indicates having taken a dose of TB medications over the past 24 hours. Green indicates 24 to 48 hours, and yellow indicates that it's been much longer. And on the basis of that, you can actually try to understand if patients have been taking medicines. Of course, this is not something that can be used programmatically, but we used some of this when the studies around MERMs and 99 dots were being carried out to just understand if patients were being able to take medicines on a regular basis and report around that. The last question was around AI, and I think this is still a fairly new area, and there are also interesting conversations or discussions happening around the use of AI in health, and how careful we need to be about that if things go wrong. But in the recent union meeting that was held a couple of months back, there were some interesting examples around the use of a WhatsApp chatbot with AI, and this was it was just very early days. I think probably only a couple of months of trying this out in a couple of different countries, and the early experiences seem to say that there is value in that, because the chatbot kind of responds to you in ways that are specific to your needs. And the needs could be very different. There could be side effects, there could be challenges around access, there could be many different things. So the initial responses were fairly supportive of the need, but I think more data and more information is really needed to understand if it can make a real impact in the lives of TB patients.
Wonderful. So the recommendation for the urine INH as well as the chatbot thing is a takeaway point from Dr. Samir. And then with regard to adherence and patient-centric care, we are open for one question, maximum another one question from the audience. Is there any questions? Is there any other question? Fine. So just I will summarize in 1 or 2 minutes. So in this particular session, there was not much a direct talk about innovations when compared to other sessions. The reason is that morning there was a beautiful, takeaway message given by Dr. Madhukar Pai. He told innovation doesn't need to be a state-of-the-art thing. Innovation is something which should be useful to the community. He compared that RNA vaccine with that of the nutritional support which is given for the TB patients in the community. Nutrition is the greatest innovation when compared to some other laboratory product which is not getting accessed by anyone. In that way, whatever suggestion which has been given by all the panel members here, Dr. Mattoo has told about, we have to have a FDC for the DRTB as well as the child TB patient. That is something very useful for the children in the DRTB patient. And Dr. Shrivastava talked about the importance of the counseling and the patient compassionate communication for the TB patient. That is another one important area of implementation research, and where there should be a care model which has to be developed based on his suggestion. Dr. Somashekar has talked about the differential care for the vulnerable population, especially like people who are having diabetes. That is one area of innovation, and very beautifully put forward by our TB champion is the survivor-led model, and the need for the first aid for the mental health trauma faced by the TB patient is one of the beautiful suggestion. Ownership by the TB patient is something which is evolving in the TB program, but it still need to be more strong. One of the most successful story of the HIV/AIDS program is the ownership of the PLHIV survivors. Such a movement is still emerging. It has to reach its pinnacle in our NTEP program for the real ownership and sustainability of our program. And Dr. Shafiq had told about the importance of the monitoring of the drug tolerance and the side effects, and the need for patient education as well as the frontline healthcare workers education on the tracking of the side effects. That is one area for implementation research. And our resource person from Sri Lanka has told about two important points, is that continuation of the patient support even in times of the financial crisis they are facing. The continuous support. This is something very important, because India, there is one thing which we have not talked about in adherence, is the consequences of climate change and disaster and the social tensions. We are facing constant interruptions in places like Manipur or in Chennai. There is floods and there is extreme weathers and social tensions which is causing a lot of interruption for the patient. And continuous social support is something very important which we have to learn from the experiences of Sri Lanka. And Dr. Samir had told about the importance of digital adherence in terms of, chatbots are actually chatbots are not a replacement for a human counselor, but when there is nothing, chatbot could play a very important role in providing some kind of first line of information for the patient. And the urine INH testing, which he had told, could be a made in India product for detecting adherence in the TB patient at a very cheaper level. These are some of the finest important recommendation which has come up from the panel. So I am not going to, considering the time, I am not going to ask any takeaway message individually from the panel members. Whenever I finish a panel on adherence, I used to just remember one legend which I have read. Pills don't work, medicines don't work unless they are taken by the patients. Whatever innovations we make in the laboratory, whatever we do, that doesn't work unless it is taken by the patients. It is a very simple commonsensical knowledge, because the distance between the pill and the patient is so high, it is very complex. We think that automatically the pill will be taken by the patient. That is not at all possible. The complexities with the patient is feeling that cannot be understood unless we put ourselves within the shoes of the patient. Unless you start feeling as a TB patient, this distance between the pill and patient will not be reduced. I think with this take-home message, I thank all the panel members and all the participants here for making this discussion in a very productive way. Thank you. Thank you.
I thank you, Dr. Karikalan, for the wonderful moderation. I request you to, if you please, could greet our panelists with a short memento.
Thank you. Congratulations. Very well done.
Thank you. A big round of applause, please, for our panelists. Thank you. Thank you for the wonderful discussion.